Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are three categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are three things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive two-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive two-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
And good morning, everyone, and welcome to day 3 of PerfWeb 27. I'm your host, Joe Basha. Thank you very much for joining us all this morning. Let's go right into our social media things. I think everybody knows we need to like, share, subscribe, click bell, do all of that stuff on the Facebook and the Twitter and the YouTube. And also our new LinkedIn account. If you look at that there, that tells you everything you need to do there. And we have our call-in number. There it is. Write it down, 347-694-4400, please. I also like to talk to everybody about joining our faculty if you would like to do that. and contribute to PerfWeb and the education of our colleagues. Also, we're, of course, doing the Nurse Web coming up too. So if you're a nurse out there watching, or a nurse practitioner, advanced practice, PA, CRNA, doesn't make any difference, or even physicians that may be watching, please let us know by going to perfweb.us to the bottom of the page. Fill that information out and send it to me, and we will be right back. Please put your telephone number so we can call you if you don't mind, and we will be in touch with you regarding that. We'd love to add to our faculty. So let me do some introductions. I think everybody already knows immediately to my right, Tammy Sparacino. She's been here with us, perfusionist extraordinaire, for the past 2 days, and on other programs as well. You'll be seeing a lot of her. To her right, of course, is Katie Kim. She has a master's in nursing, and she is the new Director of Education for Guardia Ecmo training and for MediWeb and our Nurse Web and Nurse CE projects. So welcome again. We saw her the last 2 days as well. You'll be seeing a lot more of her as well. And then there is Dr. Balan, all on the end, bringing up the right side of me, the left side of you, I think. And he is a board-certified physician and assistant professor for the Department of Internal Medicine at the McGovern Medical School at the University of Texas Health Science Center here in Houston. I know him personally and work with him in the cath lab over at Memorial TMC. And he does a lot of TAVR cases. The complex ones seem to come your way. And I think he's both an extremely capable clinician, a very compassionate physician, and really just a very nice person who I feel very privileged to know, and more so to have here. This is your second time here, actually. So welcome again to our studios. And we want to thank you for taking the time out of your Saturday to come and speak to all of us regarding these two, what we consider very important topics. So welcome, Dr. Balan, Katie, Tammy, everybody, good morning.
Good morning.
Good morning. Thank you for having me, and thank you for giving me the opportunity to talk a little bit about TAVR. I think this is actually a crucial moment in the development of TAVR. I've titled this talk, Maturation of a Transformational Technology. The reason being, we've spent the last decade doing a series of clinical trials in which we've been able to show the efficacy and safety of this technology that allows us to now replace the primary valve that connects the heart to the rest of the body in a purely percutaneous manner. This had previously been entirely the realm of surgery, but now is something that we can do in a much less invasive manner. I have a few disclosures to reveal there, and I do have to indicate that I have been part of the partner trials in an unpaid manner as part of the case review board. So in terms of this landscape of TAVR, there are really 6 large clinical trials that have been performed over the course of the last decade. 3 in the setting of the balloon expandable device, the Edwards Sapien device, and then 3 analogous trials in the setting of the self-expanding Medtronic core valve. And basically what we've done is walk down the surgical risk continuum. The original trials back in the late 2000s looked at patients who were either ineligible for surgery or at high risk for morbidity and mortality at open heart surgery. Typically, these were patients with STS scores of 8 or above. That was the original partner trial and the original core valve pivotal trial. Once those trials wrapped up in the early 2010s, the next phase was to move into intermediate surgical risk patients. And that's where the Partner 2 trial and the SIR-TAVI trial came up. And again, these were patients with STS scores in the intermediate range, typically between 3 or 4 and about 8. Again, we saw fantastic outcomes for TAVR in this intermediate risk cohort, and then the last phase was to move into the low risk cohort, those with STS scores below 3 or 4. and that was the Partner 3 trial and the core valve Evolute low risk trial, both of which were just announced at ACC this past spring. And we'll talk about those results as well. So essentially, as I mentioned, we've walked down the surgical risk continuum over the last decade and seen that TAVR is in fact a very viable alternative to surgery in all of these surgical risk categories. At the same time as we walked down the surgical risk continuum, we also saw a rapid progression in the technology within the TAVR devices themselves. We've seen 3 generations of both the balloon expandable and the self-expanding platform. From the balloon expandable side, we went from the Sapien to the Sapien XT and finally to the Sapien 3 valve, which is now the workhorse of the balloon expandable platform. And similarly, in the self-expanding platform, we went from the original core valve or core valve classic to the Evolute R, and now to their workhorse, the Evolute Pro. And you'll see how the trial data and the evolution, the iteration of the technology both interact with one another to potentially, and not just potentially, actually produce better outcomes for patients over time. So let's begin with the original trial in this field, and that was the original Partner trial. This enrolled in the United States between about 2007 and about 2010. And there were 2 cohorts in this trial. Cohort B consisted of the inoperable patients. These were patients typically with STS scores above 15 that were deemed by a surgeon not to be a surgical candidate. And the reason they started with this population was primarily because this was truly the unmet need. There were studies from the pre-TAVR era looking at how many patients with severe aortic stenosis were even offered surgical AVR. And the estimates were that up to 40 to 50% of the patients with this condition were not even offered surgery because they were deemed ineligible for surgery based on their age, comorbidities, other factors that made them poor surgical candidates. So there was the huge unmet need. So with Cohort B, what we did was we randomized those patients to either TAVR, transfemoral TAVR, or medical therapy. And what were the results of that? Here are the Kaplan-Meier curves. Replacing the valve as compared to nothing portended a substantial mortality benefit. And you can see that mortality benefit from 12 months to 24 months actually grew from 20 to 25%. Basically, medical therapy for this condition is hospice. You have to replace the valve if you are going to see a mortality benefit for these patients. So that one was a slam dunk. Next up, Cohort A. These were the patients that, while still surgical candidates, they were high surgical risk. Okay? Typically STS scores, as I said, between 8 and 15. These patients were randomized 1-to-1 between TAVR, both from a transfemoral or an alternative access approach, which oftentimes was transapical at that time, versus surgical aortic valve replacement. And this was powered as a non-inferiority trial. And here you can see the Kaplan-Meier curves, and they hug one another effectively, proving that TAVR in a high surgical risk population is non-inferior to surgical AVR. Based on these results, in 2012, the FDA offered approval for TAVR in patients who are either inoperable or at high surgical risk. Now, at the same time, or a little bit after that actually, the self-expanding platform was coming into its own in terms of clinical trials. And the key trial there was the CoreValve US pivotal trial. And their trial was organized very similarly to the original Partner trial. They called the inoperable cohort, or Cohort B here, the extreme risk cohort, and those patients were randomized to, actually they weren't randomized, they were just a registry given transfemoral TAVR. And the other cohort, the high risk cohort, were randomized 1-to-1 between TAVR and surgical AVR. And as I said, this was not truly randomized in the inoperable cohort because at this time the original partner trial had already been published and it was deemed unethical to randomize patients to medical therapy given the fact that we knew TAVR was effective in saving lives. As a result, that extreme risk cohort was measured against a statistical performance goal. And you can see the Kaplan-Meier curve here for that. TAVR, using the self-expanding platform, more than met the expected statistical targets, proving that TAVR with a self-expanding platform in inoperable patients saved lives. Moving now into the intermediate risk realm. Based on those two trials, partner and the CoreValve US pivotal trial, we now knew that the high-risk inoperable patients benefited from TAVR. The next step was to move into the intermediate risk population, and this is where the Partner 2 trial begins. This was a randomized controlled trial looking at patients at intermediate surgical risk, STS scores typically between 4 and 8. These patients were randomized 1-to-1, TAVR versus surgical AVR, and that was TF TAVR or alternative access TAVR, depending on the availability of femoral access for these patients. The valve used for this study was the second generation balloon expandable prosthesis, not the original SAPIEN valve. So as I mentioned, the technology continues to progress in terms of the valve and the delivery systems as we are gathering this evidence about the safety and efficacy of TAVR. So using the second generation SAPIEN XT valve, we then looked at the primary endpoint of all-cause mortality or disabling stroke at 2 years. And this is really where my introduction to TAVR came. I was a fellow back in 2011, just as we were beginning the Partner 2 trial here in Houston, and it was my opportunity to learn this from the ground up. And here's the Kaplan-Meier curves for the Partner 2 trial. Looking at the entire cohort, both the transfemoral arm and the alternative access arm, powered for non-inferiority for the primary endpoint of all-cause mortality or disabling stroke, you can see the curves are relatively identical. There seems to be a slight tendency in favor of TAVR, but not statistically significant when you look at the overall population, including transfemoral and alternative access. However, when you look at just the transfemoral patients, those who did have access to have a purely percutaneous transfemoral TAVR, not requiring any form of surgical cut down, now all of a sudden those Kaplan-Meier curves diverge significantly from one another. This was not powered as a superiority trial, so we cannot claim superiority based on this, but those two curves are statistically significantly different from one another. So the takeaway from this was TAVR using SAPIEN XT and surgery are similar, i.e. TAVR is non-inferior to surgery for the primary endpoint of all-cause mortality or disabling stroke at 2 years. There was this trend towards superiority in the transfemoral cohort. So the next step was to think about what happens when we bring in an even better valve, the third generation valve, the SAPIEN 3. The technology was actually moving faster than the rate of the trials. So as Partner 2 with SAPIEN XT was enrolling, we already had the third generation SAPIEN 3 valve, which had a significant number of advantages to it. Primarily, you see there that PTFE skirt at the bottom of the valve. That skirt minimized the amount of paravalvular regurgitation. In the first two generations of the valve, one of the significant Achilles heels of TAVR, particularly as compared to surgical AVR, was paravalvular leak. Unlike surgery, we're not cutting out the old valve. We don't have a sewing ring that's completely adherent to the aorta. It's merely a stent. And as a result, we saw fairly significant rates of paravalvular regurgitation in the first 2 generations of the valve. And there were studies indicating that moderate or more paravalvular regurgitation did in fact affect mortality for these patients. So it was critical to minimize that paravalvular regurgitation. And that's really the advantage that that SAPIEN 3 valve provided. Beyond that, it was also a valve that was significantly easier to deliver, lower caliber delivery system, 14 French as compared to the original 24 French SAPIEN systems.
Lord, that's huge.
Exactly. The delivery systems for all these valves got smaller and smaller and smaller over time, which meant less invasiveness, less chance for mortality and morbidity for the patients. So as I said, the technology got better and better. So rather than randomizing these patients, the decision that the FDA made based on the quality of the data from the previous trials was to merely compare a non-randomized registry of patients with SAPIEN 3 against the surgical arm of Partner 2A. It was a propensity-matched analysis whereby both a high-risk cohort receiving SAPIEN 3 and an intermediate-risk cohort receiving SAPIEN 3 were then compared to that surgical cohort from Partner 2A. In terms of the characteristics, in the SAPIEN 3 high-risk group, the average STS score was 8.6%, the average age just about 83 years, and most of these patients were treated from a transfemoral route. As we mentioned, the delivery systems were getting smaller and smaller, and as a result, the bulk of these patients could be treated purely percutaneously via the transfemoral route. By far the best form of TAVR, what the data has shown us, is this minimally invasive, non-surgical, transfemoral TAVR. Similarly, looking at the intermediate risk group, again, the majority were treated transfemorally, here even higher, 89%. The average STS score in this cohort was 5.3%, average age about 82 years. So still a relatively older cohort. And here's the data from that. When you look at both the intermediate risk and the high risk SAPIEN 3 cohorts, the morbidity and mortality is all in the neighborhood of 1%. Fantastic numbers. No other trial up to this point had showed mortality rates at 30 days this low. Okay? Even when you looked at the alternative access cohort, in the high-risk patients, morbidity and mortality was a little bit higher. But look at the far right there, the intermediate risk S3 cohort. Even with alternative access, we're looking at mortality rates less than 2%. Fantastic results. This was a huge leap forward. That third generation was a huge leap forward, an exponential leap forward as compared to the first 2 generations.
I mean, that's far superior to surgical.
And that's exactly what
numbers.
the data is going to show us. Exactly. So in terms of this comparison to the surgical cohort, it was retrospective, obviously, because we have this registry of S3 patients that we're going to retrospectively compare to the surgical arm of Partner 2A. They were propensity matched, so that it was an even match. And the 3 endpoints that we were looking at were all-cause mortality, disabling stroke, and aortic regurgitation, moderate or greater. The goal, as we said, was to evaluate at 1 year for these endpoints with this pre-specified propensity score analysis. It was all-cause mortality, stroke, or moderate AR at 1 year. And here's the results. First off, looking at it from a non-inferiority standpoint, in order to meet the non-inferiority criterion, TAVR would have to fall somewhere to the left of that blue line. The red square there at the left is where TAVR actually fell, so easily met the non-inferiority criterion. Looking at it from a superiority standpoint, anywhere to the left of 0 favors TAVR. And you can see, just as Joe points out, these are numbers that are well ahead of anything that has ever been published in the surgical literature. Looking at which of these endpoints drove that superiority for TAVR, it was a mortality advantage. So this was not anything soft. There was a true mortality advantage in favor of TAVR for intermediate risk patients. There were fewer strokes among the TAVR patients as well. The only Achilles heel, the only place where surgery continued to win, was in the realm of aortic regurgitation post-valve replacement. So the conclusion from this sub-analysis of PARTNER 2A and the SAPIEN 3 high-risk and intermediate-risk registries was that TAVR with a SAPIEN 3 valve was superior with respect to mortality as well as stroke, whereas surgery remained superior from the standpoint of minimizing aortic regurgitation. Now, at the same time, looking back at the self-expanding platform, the same story plays out over here. This is the SIR-TAVI trial that Dr. Reardon, Dr. Kleinman from Methodist next door to us conducted. Intermediate surgical risk patients randomized to TAVR versus SAVR. And again, they saw very much the same story here. Looking at the endpoint of all-cause mortality or disabling stroke, powered as a non-inferiority trial, TAVR was again non-inferior to SAVR. And again, when you look from a sub-study standpoint, there were a number of indications that TAVR, from a mortality and a stroke standpoint, was actually better than surgical AVR. So that completes the second phase here. Among the intermediate risk population, intermediate surgical risk population, TAVR really has shown benefit both with the balloon expandable and the self-expanding platform. So the final frontier was to move into the low risk population. Patients with severe AS at low risk for surgical AVR. STS scores of less than 4 in the PARTNER 3 trial, randomized 1-to-1 transfemoral TAVR versus surgery. The primary endpoint, all-cause mortality, all strokes, and rehospitalization at 1 year. Follow-up was at various intervals and ongoing through 10 years. So the interesting thing about this trial is we'll continue to follow these patients going forward to really understand durability. So we'll be able to answer that question in a decade or so as well. There were a series of registries here looking at some alternative access, but the primary arm of this trial was purely transfemoral TAVR versus surgical AVR. And here's the results. This knocked everyone's socks off. It wasn't just a win, it was a slam dunk. And keep in mind, this was a huge surprise to all of us who participated in this trial and have done this for nearly a decade now. This is surgery's wheelhouse. Surgery does really well with low-risk patients. It is a beautiful and elegant procedure to save these patients' lives. Yet, even here, TAVR outperforms surgery. Looking at each of the underlying endpoints here, and it wasn't driven primarily by the rehospitalization piece. I know it's easy to make the argument that, well, I'm sure they weren't dissimilar, it was just the fact that surgery is more invasive. Actually not. When you look at mortality, when you look at stroke, it was all better with TAVR versus surgical AVR. And yes, there was a substantial difference in the rates of rehospitalization.
Death is less than 50%. Yeah.
Correct. This is a substantially less invasive procedure that provides as good, if not better, a hemodynamic result with less morbidity and mortality. Same thing on the self-expanding side of the equation. The Evolute low-risk trial, 1-to-1 randomization, TAVR versus SAVR, and for the primary endpoint of mortality or disabling stroke at 2 years. Here's their Kaplan-Meier curve, again from New England Journal of Medicine. This was presented at ACC and published at the same time in NEJM. TAVR beats surgery among low-risk surgical patients. And looking at each of the endpoints here, this is all-cause mortality or disabling stroke. You can see statistically significant difference in favor of TAVR here. Looking at mortality alone, oops, went too fast there. Looking at mortality alone, again, TAVR beats SAVR. Looking at strokes, here there's a substantial difference. The stroke rate is substantially lower with TAVR than with SAVR. And in terms of rehospitalization, yeah, it's a huge margin here simply because of the less invasive nature of the procedure. So
Well, it's still 50. I don't mean to interrupt you. Go back to that slide, do you mind? Yes, it is a huge, but it's 50%. Your mortality was greater than 50%. So yeah, the number may be different, 2.5 versus 1, and 6.4 versus 3.1 just sounds like bigger numbers, but actually the death benefit is a higher percentage than this percentage by a small
the number
amount.
needed to treat to save a life is relatively low in these trials, which is amazing.
Yeah, yeah. Yeah, that's pretty impressive. I haven't seen this data yet. This is the first time I've seen it. I've heard about it.
Yeah, it's like I said, it knocked everyone's socks off. And the interesting thing about it was we saw 2 trials in the balloon expandable and the self-expanding realm that were very analogous to one another, and the results are almost identical. What that tells us is it's not a matter of what platform you're using, it's TAVR. TAVR works. It's safe, it's efficacious for any patient who potentially has severe aortic stenosis. Now that doesn't mean surgery's done. There are many indications where a patient needs surgery, bicuspids, those with ascending aneurysms, endocarditis. All of these other things still are very much the realm of surgery, and I hope surgery never goes away. It's a partnership. We work as a heart team. Dr. Nguyen and I, he's my surgical partner, Dr. Estrella as well. We work very, very closely and try to choose what is the right procedure for any given patient.
Mm-hmm.
So to repeat, this is the landscape that we've seen over the course of the last decade. We've marched down that surgical risk continuum. We now know that TAVR is safe and efficacious for patients at any level of surgical risk, and potentially better for the average patient with severe aortic stenosis. Thank you.
Wow.
Very nice.
Okay, very good. That was excellent.
That's awesome.
Wow, that was impressive. That was really impressive data. So we're going to do I think your next talk is, somehow tethered into this.
Yes.
And there's some crossover. So why don't we do this? How about if we take a short 10-minute break, and we can get new coffee. You guys out there can get your coffee cups refreshed, and then we'll come back and jump right into your second one, then open the phone lines and start with the discussion. Does that work well for everybody?
That sounds great.
Okay, so let's do that. Well, 10 minutes though. We're going to keep it short. So 10-minute break, everyone. We'll see you back to the program.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are 3 categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are 3 things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive 2-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive 2-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality-packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perforation, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
And welcome back, everyone, to part 2 of Dr. Balan's lectures today, TAVR bailout. Dr. Balan.
Thank you, Joe. So in this portion of the talk, I want to kind of marry what we talked about just a moment ago to dealing with some of the complications that happen. We've just seen the data showing that TAVR is safe and effective, but that doesn't mean that there aren't complications. And really what I want to get into is talking a little bit about where TAVR is going from here. Now that we know that it is a safe and effective treatment for severe aortic stenosis, TAVR is going to diffuse out of the quaternary care centers, out of the academic centers, and really disperse out into the community. And there are good reasons for that to happen, and we'll talk about those reasons. But we need to be prepared. How do we deal with the complications? Because although that complication rate is low, when there are complications, they can be quite significant, and one needs significant hemodynamic support. So what are some of the complications that can occur with TAVR? Perforation of the heart, RV or LV. RV perforations are a little simpler. LV perforations typically require opening the chest. Obviously, pericardial effusions, tamponade, that can be dealt with percutaneously, but in the meantime, one occasionally does need the hemodynamic support to get the patient through. Probably the most feared complication is annular rupture. After over 1,000 cases, I've seen 2 of these. It's usually devastating. There oftentimes is no bailout for annular rupture. Coronary obstruction. This can be an issue both from the standpoint of the native leaflets folding up and potentially blocking access to the coronaries, or embolization of calcium from the native valve down the coronaries. We have seen a few of these MIs, and we'll look at a case as we go through this talk. Go ahead.
No, go ahead. I was just thinking to myself.
Valve embolization, that is also relatively rare complication. If it embolizes forward into the aorta, that can be dealt with. As long as it maintains its orientation, you can actually just deploy it somewhere in the aorta and keep moving and put a second valve in. Embolization into the ventricle, which is what you see on the right there, is a whole other story. That needs to be dealt with surgically. So this is a patient that had to go on pump and went to the OR. That valve was removed from the ventricle and a surgical valve placed. Severe paravalvular regurgitation, that is also something that can cause acute severe hemodynamic instability and is difficult to deal with. Aortic disruptions, aortic dissections have been seen, and that too will require surgical intervention and hemodynamic support. Major vascular injury, disruption of the iliofemoral system and so forth can also create major problems, as well as hemorrhage. Now, in terms of the background here, in 2012, based on the original partner trial and pivotal trial, core valve pivotal trial data, when the FDA provided approval for TAVR, the Centers for Medicaid and Medicare Services provided this national coverage decision in 2012 regarding coverage for TAVR, payment for TAVR. And the essence of this was that a hospital must have substantial experience with both percutaneous interventions and surgical interventions in order to undertake a TAVR program. They required that hospitals have 50 or more surgical AVRs per year and 400 or more percutaneous coronary interventions per year. And that heart team, from the standpoint of the individual interventional cardiologist and surgeon, the surgeon would have to have greater than 100 lifetime AVRs and the interventional cardiologist greater than 100 left-sided structural heart procedures. These were relatively high bars. There are few centers and few operators at that time that had these kinds of numbers. So it was primarily the large academic centers, the quaternary care centers, that were able to meet the requirements of the original national coverage decision. And we did see a steady growth of TAVR in this era of the 2012 NCD, but it topped out at about 500 to 600 centers that were performing TAVR. And we saw a lot of TAVRs performed by those centers. You can see by 2016, the number of TAVRs was approaching 35,000.
Wow.
Now, does this mean that TAVR should stay with those highly experienced 500 to 600 sites around the country that do a lot of this? People looked into this. This is some data from John Carroll in the TVT database. There is a registry. Part of the NCD requirement was if an institution is going to be doing TAVR, they must report all of their data, all of the commercial cases are reported to the TVT registry. And from that database, we've been able to see what have we been doing? Has it been effective? Are we doing this safely? Are we doing this well? So it's an extraordinarily rich bank of data from which we've been able to study our outcomes. And one of the things that was looked at by John Carroll was the relationship between procedure volume and outcome. The presumption of the national coverage decision was that volume was a key determinant for outcomes in the setting of TAVR. So the purpose of the study was to examine that hypothesis, and luckily with this TVT registry, they were able to do this with a very large population. Nearly 43,000 patients were studied from the registry. And here's what they found. There is a very clear learning curve to this. The inflection point comes at about 200 cases. You really see that downturn in mortality rates once a center gets beyond about that 200th case. Like anything else in life, learning a bike, you have to fall sometimes in order to really learn how to ride a bike well. And this very elegant data using this large TVT registry shows us that it's about 200 cases that you need to get to that point where now you're zipping along on that bike and doing really, really well and achieving the kinds of outcomes, mortality rates less than 1 to 2%. Those can be achieved once you have that level of experience. Now, again, that would lead a lot of people to say, well, then TAVR should be restricted only to those centers that have very large volume. Our center, we've done over 2,500 cases, I think, at this point. We're probably approaching 3,000 cases. I've lost count. Not every center can have that level of experience, nor can every patient travel from wherever they are to the Texas Medical Center to come have their TAVR. There is a serious issue regarding access to care here, okay? When you look at the United States map here, you can still see there are a lot more states that have more surgical centers than they do TAVR-capable centers. And Texas is among those states here. And this was some very interesting data looking at less well-served populations. This was from an article that came out late May, early June of this year in JACC Interventions, looking at rates of TAVR among traditionally underserved populations, African Americans, Hispanics, socioeconomically disadvantaged groups. While you see the growth in the number of TAVR centers in that dotted line at the top, the rates over time of TAVR availability for these minority groups doesn't budge. The disease does not discriminate. The rates of severe aortic stenosis among African Americans, Hispanics, whites, Asians, it's all the same. It's 7% of the population over 65. The disease does not discriminate. Yet access to care does appear to be differential for these patients. So with that in mind, CMS released a new national coverage decision in early June of this year, trying to improve access to care. And this is, of course, in the background of all of the data we've seen showing us that TAVR is a tremendously safe and effective technology. We need to make this technology more available to more patients. And that's really the gist of the new national coverage decision. Rather than requiring 50 or more surgical AVRs per year, that requirement is now 50 or more open heart procedures. So any open heart procedures, CABs, now count towards qualification to be a TAVR site. And the PCI requirement has gone from 400 to now 300 per year. So in sum, this new national coverage decision reduces the volume requirements. There are still substantial volume requirements, certainly from the interventional side, in order to maintain that quality piece so that we meet that volume outcome relationship that we know exists. We have to maintain the quality, we want experienced operators, but we want this to diffuse into the community so that more people have the opportunity to access this transformational technology. Of course, what that means is we're now going to have some of these potentially devastating complications, not just in the academic quaternary care centers where we've got every machine, every tool, everyone, all hands on deck. Now it's going to be happening in more of the community hospitals around the country, and we need to be prepared for that. It's still going to be a partnership between CT surgery and interventional cardiology. The CMS requirement still requires that the procedure be done in a combined fashion between the two disciplines. However, the question isn't really about surgical backup. When something truly does go wrong, before you can get to a surgical fix, you've got to have some form of support. And that's where Ecmo really comes in. So when we think about it from the Ecmo standpoint, what are our traditional indications for Ecmo? Your goal with Ecmo is typically a bridge to recovery or to some other form of life-saving technology, whether transplantation or destination therapy with a VAD. In the TAVR situation, when things go wrong, it's going to happen very fast, and your only goal here is to get yourself a bridge to something. We'll figure out what that something is once we get there. Okay. Now, in terms of access, with the traditional transfemoral TAVR, this is a picture of a case from a few years ago. And part of the reason I put this in, you see the large sheath over there on the patient's right near my hands. On the contralateral side, what you see is a 6 French sheath in the left femoral artery and a 5 French sheath in the left femoral vein. The arterial sheath is being used for the pigtail, which allows us to monitor and inject during the case, allows us to see the valve as we're deploying it. That 5 French sheath, though, is purely there for bailout. If something does go wrong, you can take those 2 access points and get yourself onto VA Ecmo very, very quickly. So here's a case example. This was a case from earlier this year. Valve deployment goes beautifully, perfect looking valve. However, we have a problem. Anyone see what the problem is here?
Yeah, your coronary is obstructed.
Yeah, there's no right coronary now. You see the left main, but the right coronary, trust me, she did have a right coronary before this. And we saw it on the monitor as well. Within a few minutes, you began to see the ST elevations, and you can see the pressure is beginning to drop. She'd started the case with a pressure in the 140s. Now we're down about 80/40. Took us a little while to engage this, but this was a coronary embolization. Basically, calcium from the valve. It's like a shark tooth-like shard of calcium that has gone down this somewhat high anterior right coronary artery. This was a case where, I didn't think about coronary protection at all, because that right coronary is about 19 millimeters above the plane of the annulus. You can see it's well above even the frame of the valve. Likely what happened here was a chunk of calcium from the valve itself flew off and lodged itself into the ostium of the right coronary. So luckily we were able to engage it, get a wire down, stent, and escape the situation with a patent right coronary artery. But of course, you can see we did all of this. You can see the cannula there in the right atrium. So we were on VA Ecmo from the femoral approach.
Oh, so you went ahead and put this patient on Ecmo
Of
to
course.
do this.
That pressure of 80/40 was when we realized what was going on. It went south from there. I mean,
Clearly.
we were 60/PAL within minutes. And that's the point where we go on pump, then start fishing for that coronary. And as I said, this was a high anterior takeoff of that right. This was not easy to engage. It took me 3 different guide catheters to get an engagement that would allow me to get a wire down there. You can't spend 30 minutes at 60/PAL and expect the patient to do well. You're going to be in multi-organ failure. Ecmo gives us that bailout whereby I can support the patient, get them through this, give me enough time to fix the underlying problem, and then bail the patient out. So in terms of your most common bailout strategy in terms of VA Ecmo, it's going to be FEM-FEM VA Ecmo. And this is traditionally what that looks like. This is just a stock picture that Joe provided me of the arterial return cannula and the venous drainage cannula there. As I said, typically we prepare for that kind of access at the start of the case. With every TF TAVR, I like to have a bailout vein, and you've already got an accessory artery in the groin that you can then just take for your VA Ecmo. Now, what if you're dealing with an alternative access case, okay? Here's a patient I treated in late 2018. That's her distal aorta. Obviously, you can't do a TAVR from down in the femoral artery, so this is one where we went percutaneously from the axillary artery. We were able to get a wire up from the femoral. Don't ask me how I did that, but we did. From the right, it was actually accessible. We then aimed for the wire, and you can see the needle coming in from the right. That circular density that you see there over the fingers, that's my wedding ring. As I'm getting percutaneous access, you can see that's what we're fluoroing there. So you can gain access percutaneously to the axillary artery and then put your delivery sheath in from there. Now, if something goes wrong with this kind of case, you can use that arteriotomy for your arterial return cannula. That's a 14 French sheath. You can simply, it's already pre-closed at the beginning of the case. You can simply exchange that for a 15, a 17, whatever size cannula.
Is that 14 French OD outer
ID.
diameter?
Yeah.
16 ID. 16 OD.
OD. Okay, so a 17 would easily fit.
Would
If
easily
you could put
fit.
this in, you could put that in.
You could easily fit in
Okay,
a
fair
17
enough.
French cannula. Exactly. So that's the rare circumstance where you have to do that. We do percutaneous axillary and things relatively rarely. As I showed you, nearly 90+% of the cases are now purely transfemoral. So I just show you that as a potential alternative. Going back to the transfemoral situation, what are some of the complications you need to avoid of transfemoral ECMO cannulation? Well, if you put a 17 or a 19 French in the femoral artery, particularly in smaller individuals or individuals who have some degree of peripheral arterial disease, you're going to lose perfusion to the leg, particularly if you're going to leave them on ECMO support as you leave the cath lab or hybrid room and go up to the intensive care unit. You don't want a dead foot or leg saving the patient's life and losing their leg is sometimes a worthwhile bargain, but that's not the optimal goal here. Okay. How do you deal with that? You need a retrograde sheath. You can see the sheath traveling towards the patient's toes there on the right. That is a 7 French braided arrow sheath that is traveling in the other direction down towards the patient's feet, and it's hooked into the arterial return cannula. So blood is basically flowing in that arterial return cannula through the sidearm of that sheath back down that patient's leg. So even if that arterial cannula is completely occlusive, you now have a blood supply from that cannula down the leg so that you don't lose the leg.
I see they're using NIRS because, of course, you on the calf to look at saturation because, of course, you won't get a Doppler pulse.
Correct. It's
No
going to be
pulse.
continuous flow.
Continuous flow. But if you use NIRS, you at least know the saturation. We were talking about NIRS yesterday, remember?
about this
I'm
exact
sorry,
thing.
please.
No, so it's a fantastic picture. It's become standard procedure now at our institution. If you're placing the cannula, don't take a risk with that leg. Just go ahead and place the antegrade sheath. Make sure that there are no issues there. It is not worth losing the leg to save the patient's leg, particularly when a simple solution like this allows you to preserve flow to the leg.
Right. Yeah. And I think what you're saying is that right. It's not. If that was the trade-off, life or your leg, yeah. Well, life comes first. But right, your point you're trying to make, I think, is that there's no need to lose the foot.
Correct.
So why lose it when you don't have to for a simple solution?
Exactly. Okay. Now, last potential complication of going on VA ECMO as bailout for these patients, differential hypoxemia, okay, sometimes called Harlequin Syndrome or North-South Syndrome. Keep in mind that with some of these patients, their lungs can get flooded during the process of decompensation, okay? A coronary issue, for example, heart's not pumping well, things are backing up behind the heart, they go into acute pulmonary edema. All of a sudden, it's really not well oxygenated blood that is being delivered from the right to the left side of the heart. Now, oftentimes we have successfully replaced the valve at this point while we're dealing with whatever the complication is. That heart may potentially be ejecting, but it's going to be ejecting through your new valve relatively deoxygenated blood. And that means what the great vessels are seeing up top may well be relatively blue blood. And therefore your brain may not be getting as much perfusion as your lower extremities. That is a suboptimal situation, and yes, I have seen patients develop anoxic brain injury because of this situation going undetected. While it's bad to lose your leg, it's even worse to lose your brain.
Yes,
Right.
I just
Right.
presented a case, was it yesterday?
Thursday.
I think Thursday, of a similar situation, and on a 21-year-old.
The key to avoiding this is making sure that you are checking your arterial blood gas at a point that is as distant from the arterial return cannula as possible. So in most of these cases, if the arterial return cannula is in the left femoral artery, you place the radial art line in the right radial artery. That oxygen saturation, that PO2 is likely what the brain is seeing. So if you're seeing low PO2s over here, that's probably what the brain is seeing, and you need to do something to fix that. And typically the fix for that, there are a number of ways that you can fix this, but probably the simplest and most elegant solution is to simply Y your arterial return cannula and return red blood to the venous circulation up top, so that what's being returned to the right heart is now well perfused oxygenated blood. So that gets transferred to the left, and that ejecting LV then pumps oxygenated blood to the brain. So those are just some of the bailout strategies and considerations that we need to think about. And I think this is very important because TAVR, as we've seen from the data and the change in the federal government's stance on this, is going to diffuse all across the country, all across the community. It is a wonderful technology, and we're all going to be using it. But let's face it, there are going to be that 1% of patients who face significant complications. And what are you going to do with that 1%? You need to be prepared. Typically, when these complications occur, they are devastating. there's going to be severe hemodynamic compromise, and you are going to have to put them on a substantial form of hemodynamic support. By far, in terms of flexibility and ease of use, Ecmo is the answer here. It's harder to have a full heart-lung machine in place in a cath lab. Less substantial forms of support may not give you the ability to oxygenate and ventilate the way Ecmo does.
Well, it's also very easy
Correct.
to transition from Ecmo to full cardiopulmonary bypass.
Correct.
I mean, it's really not, it's a pretty simple thing to do.
Correct. Or step down if you need to if the patient's recovering.
Sure, right, but yeah, right, you have those options. Exactly.
It's that nice middle ground that it gives you. It gives you enough time to fully support the patient, fix the underlying problem. If you need to go to the OR and convert to full cardiopulmonary bypass, you can. If you're bridging to an acute recovery, you can step them down very easily to an Impella, a balloon pump, whatever you need to take them up to the unit.
Or leave them on that. And
Or leave them on
transporting somebody on an ECMO is a whole lot easier than when they're on full cardiopulmonary bypass.
Yes.
Much easier to do.
Exactly.
Clearly.
So ECMO serves as a fantastic bailout under these circumstances. And I think as a community, we're now all going to have to become much more facile and familiar with how to use ECMO as a technology for bailout, since TAVR is going to become so much more widespread. Thank you.
Very good.
Thank
Excellent.
you. Thank you.
Very good. Are there any questions from our studio audience? Oh, there's nobody back there in our studio audience. Our studio audience has abandoned us. Yeah, really, really good. I have one very fast question because I'm going to forget it if I don't, and then I'm going to let Tammy and Kim or Katie ask their questions first. But on the cannulation, I saw that you put in you have your pigtail in the contralateral femoral artery from where you're doing your procedure, your delivery system site, or your dry sheath, I guess that's what it is, a big gore dry sheath or something.
So the dry sheath or the Edwards E sheath, depending on which system you're using.
Whichever it is, but your sheath. And then you have your femoral vein with just a line and a wire in it so that you can, or a catheter so you can exchange it and put a catheter in. Some people have told me that they just use the sheath and put a 17 French, I think it's the Medtronic catheter, just right through that sheath and use that. But if you do that, you no longer have I'm assuming the ability to continue with the procedure unless you then reinsert another delivery sheath in the other side. So do you have a preference either way as to which one you think works best?
I prefer to separate them, knowing what my bailout options are and my valve delivery system are, because my goal is if something happens, I want to be able to at least deliver the valve to take that issue off the table. So to give you another example, there was a case where I had an LV perforation, a wire perforation of the LV. Okay, wire migrated out.
I remember that. Well, and we thought and the patient had lousy lungs. Remember, we drew a blood gas off of the pericardial effusion, and the saturation was kind of crummy, and I was like, well, that looks venous. I mean, that's a venous number. But it ended up being the LV. I remember that.
Exactly. So with that LV perforation, if the wire had already migrated out before we had delivered the valve, and I saw the wire and I knew it was in a bad position, it, however, was tamponading the hole at that point. So my thought was, I can pull the wire back and face hemodynamic collapse now, or I can leave the wire where it is, deliver the valve, then I'm only dealing with one problem, not two problems, okay? If I don't deliver the valve, I've now got a patient with severe AS and the inability to perfuse herself and tamponade at the same time. Once I drop the valve, I've taken the valve issue off the table. Now I just need to deal with the hole in the LV. Okay, which is much easier because we tapped the pericardium, we waited to see if it auto-tamponaded, it didn't. We took her to the OR, surgeon placed one stitch. Didn't even have to go on bypass to do this.
Right, sure. Yeah, you would normally not have to. You shouldn't have to do that for that problem. But did he do a full sternotomy, or did he?
Yeah.
He did. Yes, they bought a sternotomy anyway. Hey, glad it wasn't a redo.
No, exactly.
Okay, so they,
Yeah.
the bright, there's always a shiny, there's always how does that go? A shiny cloud, how does that saying go?
Silver lining.
A silver, that's right, the silver lining, that's right, the cloud. Thank you, I appreciate it. Okay, I'm gonna let Kim, I keep calling it Kimberly.
I know, today.
I'm gonna keep letting Katie and Tammy ask their questions first.
You go ahead.
Okay, so my interest is in the actual care of the patient. So once the patient leaves the cath lab, or what can you expect for the nursing staff?
Absolutely, that's a great question, and that's something that's evolved over time. When we first started doing this back in the early, 2010s, 2011 or so, these patients were receiving 24 French sheaths. That original Sapien delivery system was 24 French, huge arteriotomies, a lot of vascular complications. Everyone was going to the CCU. They'd spend days in the hospital before they left. We didn't really know what the hemodynamic changes would be after valve replacement. We kind of relived the original era of surgical valve replacement 50 years prior. The blood pressure goes up, the blood pressure goes down, we have no idea what's happening, it's a roller coaster. All of this we have to manage in the CCU. A decade later, nearly a decade later, we now know how this goes. And for the most part, with these lower caliber delivery systems, patients are going home the next day. Okay. So rather than using the resources of an intensive care unit for relatively well patients, we simply go from the cath lab to the PACU, from there to a step-down unit. My goal is by that evening, the patient should be up in a chair. By the next day, they should be walking around. By the latter half of that day, as long as they can brush their teeth, go to the bathroom, and walk, they can go home.
Wow,
Okay.
that's nice.
Exactly. So it's much less intensive now in terms of the care of the patient. In terms of the hemodynamic piece, I do want to address that. For a long time, when the valve is stenotic, the LV is generating a supranormal pressure to get blood through that narrowed orifice. When we suddenly replace the valve, no one tells the LV you can stop generating that supranormal pressure. So a lot of these patients are markedly hypertensive immediately after the procedure. So you do need to be careful about the blood pressure in that first 24 hours post. We've learned kind of the pattern here. There's at about 24 to 36 hours, there's a baroreceptor response whereby the pressure, the body realizes, hey, wait a minute, what's all this new blood flow? And the blood pressure comes down. So you have to be careful. You need to bring the pressure down, but don't overdo it, because once they adapt, you'll floor them otherwise.
So what kind of parameters do you look for in blood pressure reduction post-TAVR?
Typically, I want to see them around 130 to 140 post-TAVR. And oftentimes what we'll use are short-acting agents, things like nicardipine drips, rather than giving them a bunch of long-acting orals, because when they do adapt, I don't want those orals still acting and dropping their
'cause you
pressure
can't take
too
them
low.
back.
Exactly.
Nice. And then when you have these big complications, and is that typically right away when you're in, like they've happened?
Yes, typically.
They've happened right away?
Yes, typically if you're having one of these devastating complications, right away. There's hemodynamic collapse.
So if you were to tell me, or if someone were to tell me, Katie, you're admitting a TAVR to the ICU, then I can expect that something terrible went wrong?
Yes and no. I wouldn't say that. Yes, the ones where there are devastating complications, they're going to go to the ICU. Occasionally, I will still send a patient to the ICU if I'm worried about, is that groin still oozing, bleeding, and I want those Q15-minute checks on that groin to make sure it doesn't well up into a retroperitoneal hematoma or something like that. But for the most part, well above 90% of these patients are going to be going the less invasive route.
Okay.
All right, I have a few questions. Are we using
just
this
me?
or
Is
just
it just
Mike?
No, just you.
Oh, was it
Because
my
your
position?
microphone's on one side, so
I'm
when you turn
sorry.
your head,
Oh,
they can't hear you. So that's
it's like
okay.
differential hypoxemia.
I'll go that way.
It's like-
It is.
Right? It totally
This is
is.
left-right syndrome, though.
Okay, oh, that's pretty funny. All
Okay,
right.
I just have a couple questions. First off, the perivalvular leaks, what do you do about those? Do those patients have to require surgery? I mean, is there a certain amount of that can be tolerated and you think, well, it's still a success?
Absolutely, that's a great question. And as we said, that's one of the original Achilles heels of TAVR as compared to surgical AVR. What the data has shown us is that mild or less paravalvular leak seems to have no long-term consequence for these patients. However, once you get into what's echocardiographically deemed moderate or greater paravalvular leak, it does affect the long-term survival of these patients. Now, acute severe paravalvular leak, let's say we deploy the valve, it's canted, or we miss the annulus, something like that, and you've just got a wide open AI situation. That's hemodynamic collapse.
Yeah.
And at that point, what you need to do is actually deliver a second valve. Okay, so that tends to be the bailout there. You put a valve within a valve under those circumstances and try to seal that original valve. But you may need hemodynamic support in the interim because it's going to take you about 10 to 15 minutes to get that second valve up there. And that's where the Ecmo comes in. Now, I know AI in the setting of Ecmo, you're potentially flooding that LV. However, typically this is a short duration. And that's also part of why I prefer to maintain the access site separately, to go back to the other question that was mentioned. If you can support from one side and deliver from the other, you have the ability to take care of the whole situation.
Okay, that actually leads right into your solution, leads right into my next question. As far as what do we, I know it's early to know, but what I understand the plan if you have to have a replacement valve, like if you're doing this on a younger patient that's going to outlive their valve, it's just a valve that's placed inside of a valve. Is that correct?
Correct. That gets to the durability issue. And we mentioned, for example, partner 3, the follow-up is 10 years here, because the low-risk patients tend to be a younger subset.
Right.
So if you're getting a TAVR at age 65, hopefully you're going to be around 10 years later.
Right.
Okay. We have not yet rigorously studied TAVR in TAVR. What has been rigorously studied is TAVR in prior surgical AVR. Okay. We know that that is a safe and effective procedure. So all of these patients that have gotten surgical AVRs that after a decade, they've gotten the value of that valve, the valve is degenerate, restenotic, et cetera. It is a relatively simple procedure to do what's called a valve-in-valve TAVR there. You simply place the TAVR prosthesis within the surgical prosthesis, and the patients do quite well. There is going to be a trial coming now for TAVR in TAVR. That is not yet an FDA-approved situation. And we have not yet seen a large number of these because happily, even the original cohort of valves that we replaced a decade ago are still doing relatively well. We've got data in Europe out to about 8 years now, in the US about 7 years, where the durability of the original valves is quite good. But you're absolutely right. We're not far from that decade or so point where some of these valves are going to start coming back dysfunctional. Have we done off-label TAVR and TAVR? Yes. It is feasible, it is doable. The next phase is to rigorously study that process.
Okay, and I just have one more question. So talking about kind of the surgical team support, what is the role that you think the surgeon has during the procedure? I know some places that, surgeons in the room, some places they're just available. I'm assuming it's a requirement that a surgeon is at least within a certain proximity that they could respond. And then if you could also expand on as far as perfusion support or circulatory support, depending on the hospital setup, is it a requirement that those people be in-house for now that we're going out to these community centers?
I'll answer each of those questions in turn. The surgical piece as to what the role of the surgeon is or should be, you're right, that varies by individual institution, individual heart team. The experience that I've had working with my surgical colleagues is we are hand in hand, okay? As I mentioned, Dr. Nguyen is my surgical partner, Dr. Estrella. We're always scrubbed in together, and we are doing the procedure together. And that is really the spirit. If you look at the language of the NCD, it says that the surgeon should be a full participant in the procedure as well, not just sitting in the control room, et cetera. And that we've really kind of lived the spirit of the heart team in that regard. And that collaboration is magical, because now we both feel very invested in the well-being of this patient. When we're making decisions as to whether a patient should have a TAVR, now that we're in this low-risk era and every patient potentially can get a TAVR, we can sit down together and talk about what is the right thing for this patient. Should they have a TAVR? Should they have a surgical AVR? You know, if you're a 60-year-old with a bicuspid valve and an ascending aneurysm, I'm sending that patient for surgery every time, okay, because that's the definitive solution for their overall pathology. I do think that different places are going to do it differently, and largely what's going to happen over time is I think interventional cardiology and CT surgery are now becoming much, much closer. I feel closer to my CT surgery colleagues than I do to my general cardiology colleagues.
Well, that's exactly the point that I was hoping you would get at, is it's important to keep this as a partnership, just from the standpoint of what's best for the patient, because if it's not, then it can definitely become a divisive thing.
Correct.
These, you know, I need my surgeries, you want your TAVRs, etc.
Right, and that is absolutely what we are hoping to avoid. There has been discussion. I sit on the SCAI Structural Heart Committee at the SCAI meeting this May. That's exactly what we talked about. As we proceed into this low-risk era, how do we avoid turning it into a rivalry rather than what it has been, which is this collaborative effort to choose what is best for the patient? And building that heart team where surgeon and IC work hand in hand and are scrubbed in together and are doing all of this together, I think really facilitates exactly the vision that you're describing.
Right. Okay.
Now, the second part of your question, the bailout piece, it is not, as far as I can tell, per the NCD, a requirement that one have Ecmo or any specific piece of hemodynamic support available. That is really left up to the individual institution and the individual heart team to choose how they are going to bail out under dire circumstances. And that really is kind of the frontier here, and that's why I brought it up in this talk. As TAVR disperses into the community, we really need to think about how we're going to do this, because we need a bailout option. As I said, Ecmo, I think, is that perfect intermediate option where it's invasive enough and provides enough support to get your patient through the acute complication, but is easy enough to deploy quickly if you need to transport, small enough, safe enough to transport effectively and easily under those circumstances. So I think we may see a substantial growth in Ecmo with the dispersion of TAVR.
Okay, thank you.
Well, yeah, but that brings up, and thank you. Those were really good questions from both of you, I thought, and I really appreciated the answers because they were thoughtful questions. You know, I'm going to be perhaps a little provocative, and you know, I know that's kind of unusual, you know, for me, but I recently gave a presentation right here on TAVR coverage. And, you know, I tend to be somewhat of a financial pragmatist, and I think we all have to be. And though I appreciate very, very much your feelings that you want that collaboration with the surgeon, having them there, the procedure, et cetera, you know, there's a part of me that questions the wisdom of that. I think that, you know, you look at, of course, the one extreme being Germany that has zero surgical coverage at all for their TAVR procedures. And though I value surgeons also, they give us all of our work, right? You do too, though. They don't give us all of it, but they give us a lot of our work, okay, going on pump. However, is it really the best thing? Is it really necessary? Is it really that beneficial? Unless you plan on immediately opening the chest and doing some kind of big surgical procedure. Most interventional cardiologists that I know, if not all, can easily put a patient on ECMO. You don't need a heart surgeon to do that. If you have a peripheral vascular complication, perhaps you will need a vascular surgeon to consult. You can always control the bleeding until somebody were able to get there, and that's going to just reduce the cost. It's not going to reduce the care. Although I love Dr. Wynn as well. I think he's a Dr. Ostrera, but Dr. Wynn, as far as I'm concerned, both of them are absolutely first-class surgeons and great at what they do. But why are we adding this cost to a procedure where, if there is a problem, their wire skills, their catheter skills, their ability to manage the situation without a knife and a saw and a pump, it really doesn't exist?
Well, I wouldn't say that it doesn't exist. Dr. Nguyen, for example, did a fellowship in percutaneous
Okay, very
valve
rarely.
replacement. There
rarely.
are some surgeons, and that's what I mentioned.
Very
the
rarely
disciplines
would
in
exist.
terms of the training over time are going to become closer. More and more surgeons are going to be learning the wire and catheter skills, and I think more and more ICs need to learn some surgical skills. We may need to learn how to cut down to a femoral artery. Having that combination of skills.
I don't think that's going to happen in our lifetime. Our
True.
practice lifetime, certainly. But go ahead, I'm sorry.
But you're absolutely correct. If we don't choose that sort of avenue where the two disciplines come closer together, I fear that they are going to go in divergent directions. And sadly, cost is what drives a lot of what we do. And I hope that that does not lead us into an era where everyone's offering a different brand of TAVR.
Well, I would hope so too, but I think that, in my sort of view of this from from both a quality and economic perspective, looking at both of those things, though it feels good to have a heart surgeon right there while you're doing the procedure, I see it. I don't see the clinical benefit more so than I see. I think if you had some type of a meeting, a committee of some sort that reviewed the procedures jointly and said this is what our option is, and any debate about how best to manage that patient would take place there. Perhaps having a heart surgeon who may have, just from physically seeing a lot of this anatomy, might have some perspective that could perhaps be of value to any operator of the catheter delivery system and the device in terms of its implantation and all of that kind of thing. But, I just watched for the first time, didn't have any idea what the procedure was until I saw 3 of them last Monday. You were there for those basilica procedures. So, and that's where they go in and they use basically already existing devices, puncture a hole. And the reason for doing the basilica procedure is that if the valve leaf of the coronary ostia rides low, I guess particularly the left coronary, rides low, and when they implant the valve, there is a risk that the native leaflet or the
bioprosthetic leaflet,
the bioprosthetic leaflet will impede on it, will open up and cover it, like what you saw with that piece of calcium, only this wouldn't be something you can easily fix. You put this wire in and you use a bovie and you energize it so it punctures a hole through the leaflet, and then you catch it with a snare and pull it through the central orifice of the valve, and then energize the wire again as you're pulling up, withdrawing it from the patient, and it essentially cuts the leaflet in 2 and opens it up. Yeah, lacerates it. And then so that when the valve gets pushed to the side, that leaflet, if it does open up that direction and not just crunches up, will open like a basilica.
Correct.
So therein lies the name. I was like, who's Dr. Basilica? I had to figure it all out, okay? So that's pretty creative. But I think that the Europeans probably have, the STS, and I certainly respect why they did what they did, which was, in order with CMS, the lobbying that if a surgeon is not there present on site during the procedure, scrubbed in, you don't get paid for it. I think the private insurers are going to eventually recognize that that is really unnecessary, and that's, I think, going to go away. It doesn't mean that I think, however, that collaboration through committee or whatever review process you have should go away, and the collaboration should go away. That I agree with you 100%.
And that remains required. The original CMS mandate indicated that there must be a valve conference. So
that's what I was trying to say, conference.
Oh, okay.
Before any of these patients can proceed with TAVR, there must be a multidisciplinary conference with interventional cardiology, cardiothoracic surgery, and all the other relevant disciplines present that review each of these cases and approve them as TAVR versus surgical AVR. And that is something that remains robust at our institution. And I agree with you, you cannot underestimate the importance of that multidisciplinary conference. That is where the team really has to come together and choose what is best for the patient. And really that was the impetus for the start of my career. I remember as a fellow I was once told, invent valve conference. So I did, because no one knew how to run that kind of conference at that time.
Well, I'll tell you this, and I think that should stay in place.
Correct.
That I believe in, because it has no cost associated with it, no real cost, but it has tremendous benefit, or very low cost if you want to say that if there were employees of the institution, yes, there's a cost associated with it, but it's low compared to benefit. But what disappoints me about these things, and it's not your fault, it's not the institution's fault, it's not the surgeon's fault, it's our fault, is that there's never perfusion representation about how do we manage the patient if there does need to be a bailout, because I think we have some unique skills and understanding of just the logistics and the dynamics of everything happening with the patient in terms of cannulation and so forth, and being on board with it. Nor is there any post-op ICU nursing in the ICU that could also potentially be contributing to those valve conferences. And so that disappoints me.
From our perspective, we do have the CCU nursing staff involved.
Great.
CCU nursing leadership is involved in our valve conference. You're right, I haven't had perfusion.
And that's not y'all's fault. That ultimately ends up being our fault. You know, we don't really find ourselves involved. And I think that
the invitation's open though.
Thank you very much. I think that our profession has sort of evolved in that direction, that we know very little about the patient. They get consulted, and I've been on multiple open heart consults where I've just stood there and just was visiting with the surgeon, and he gives his patient a consult. Okay, we're gonna take you to the operating room, we're gonna get you to sleep, we're gonna clean you up real good, we're gonna make an incision, and we're gonna open your breastbone. They never say we're gonna saw it open, or whatever, hack it apart. They never say that. And then we're going to put you on the heart-lung machine. We're going to do the operation. We're going to wean you off the heart-lung machine, and then close you up and send you to the ICU. They never ask, who runs that heart-lung machine, and what the hell is it? And what does it really do? What are you really going to do to me? It's just breezed over, because those are things that if you were to really give a true informed consent, it would start at 6 in the morning and end the next morning when you went to go do the case.
Right.
So it's limited. But we're just not involved. So we don't really know much about the patient until they get in there. Then we look at their chart. We get the basic information that we need to have. We know nothing about their family dynamic, nothing about what their interests in life are, we don't know them. They're just there. We go on pump, we do the procedure, we come off pump, patient comes off pump looking great. Oh, we tap ourselves on the back. You did such a great job today. They close them up. We kind of go with them to the ICU. We drop them off, and we leave.
Well, I think
never see them again.
I think that is very much how your perfusion practice is set up in most of the hospitals. Now, some of the larger hospitals that have very large teams often have someone who does follow-up, who might pre-op them, but on the smaller teams, it's a staffing thing, I would say, for the most part. Now, that doesn't mean your perfusion team couldn't set it up where they're, looking at the patient at least the day before, or, reading about them, those kinds of things.
But surgeons would be horrified if we went and visited the patient before they were going to operate on them. Anesthesia does. The surgeon does.
I don't agree with that, because in my last place of employment, if it was required where we needed to do a TEG, which we often did, we went and visited the patient alone in the cath lab, introduced ourselves.
I would say that's rare.
But
I would say it's rare. It does exist, and I'll grant you that. But I agree. Think it's pretty rare.
I agree. Mm-hmm. You're right. A lot of times it's once they roll out the operating room door, we're like, see ya, it was fun.
Right.
And that's it.
We don't know whether they had a stroke. We don't know whether they went into renal failure. We don't know if their post-op course was simple and beautiful or complicated as hell or whatever.
Well, that's a shortcoming in our community.
Yes, that's what I think that was my point.
I mean, that's more on us than it is on other people.
Okay, so now that we've debated that, self-expanding versus balloon expanding. Because I understand that I don't know if it's related to self-expanding or balloon expanding, but heart block seems to be higher, and I didn't see that in the data, but that doesn't mean it was not there. Just might not have been relevant to this talk. Is heart block and need for permanent pacemaker more common in self-expanding versus balloon expanding, or is it because of something else in the design of the prosthesis?
Based on the data, there has been a greater need for permanent pacing with the self-expanding prosthesis as compared to the balloon expandable prosthesis. I do think part of it has to do with the frame of the self-expanding prosthesis. It is a nitinol frame that continues to expand and therefore continues to exert pressure on the LVOT. Mm-hmm. But part of it is also under our control. It has to do with the depth of implant. If you are implanting that valve very deep in the left ventricular outflow tract, your likelihood of conduction abnormalities is substantially higher. Mm-hmm. If you implant at a lower depth, much higher up, the rates of conduction abnormalities are lower. So there are institutions that are primarily self-expanding users who see relatively low rates between 5 and 10% of pacemaker use. However, broadly, when you look at it, yes, there is a difference. With the balloon expandable platform, pacemaker rates are about 4 or 5%, whereas it's about 10 to 15% with the self-expanding.
Much higher.
Yeah. Which is absolutely.
Is there any way to know where the AV node actually is?
No.
So there's no way
Not that I know of.
So there's no way to say, we need to be above this threshold when you put a valve in.
No, we have certain ideas of where we want to implant, not just based on conduction issues, but improving the hemodynamics. Mm-hmm. The higher we place the valve, while still sealing the annulus, the better the hemodynamics, whether we're talking about a self-expanding or a balloon expandable prosthesis. Simply because the lower you seat that valve, the more constrained you are by the annulus, the lower is the effective orifice area of the prosthesis.
Sure.
The higher you can sit it up, the better orifice area you get.
Sure. No, that makes sense. I mean, back in the early days, when we did, much earlier days, having heart blocks associated with isolated aortic valve, surgical, of course, only was really pretty common. Yeah. And it was just from swelling.
Right, it's the edema.
Our techniques were just not, that good as they are now. Because now surgically, it's not that common. It's not zero, but it's not very common.
Correct.
I noticed that patients not offered valve for other reasons, that were not offered TAVR. How many of those are there of patients who are not offered TAVR for any other reason?
As in not offered any form of aortic valve replacement, or
TAVR.
referred instead for surgical AVR in place of TAVR?
Surgical AVR, no, right, referred for surgical versus TAVR.
Yeah, and we're seeing a lot more of those now in this era of the low-risk patients. The patients that I think are better served by surgery are this younger cohort of patients. If you are, for example, less than about 55 years of age, let's say, and that's where the data with mechanical surgical valves has shown the greatest benefit. Potentially, if you're in your 40s or 50s, durability really becomes a substantial issue.
Yes.
Yes, of
And
course.
a mechanical valve is what is going to provide you with the greatest durability in terms of the prosthesis. So there is a survival advantage at age 55 years or younger to go for a mechanical aortic valve. Okay. After 55, that survival advantage is less available. So once we get into the 60s and so forth, it becomes a question of surgical bioprosthetic versus transcatheter bioprosthetic. We don't yet know what the durability comparison between those two will be. Not enough time has passed to have that durability data. We expect, based on what we know at this point, that they will be roughly analogous. To your question earlier, we do know what TAVR and SAVR looks like. We know that's safe and effective. We do not as yet know what TAVR and TAVR looks like. Presumably it will be safe and effective, but we have no real data on that. So yes, in a 62-year-old with very few comorbidities, they may consider surgical aortic valve replacement, thinking a decade from now when that prosthesis fails, I'll have my cardiologist do a TAVR within the prior SAVR. That's a well-proven commodity at this point.
Yeah, I mean, that's what I would be thinking. I would be thinking that, but some things you've said, you know, I've historically not been on the TAVR train, and I think I've so far been left at the station. I mean, I think that I've been, you know, I may have not been right about this one, and I'll tell you why with the next couple of questions, but go ahead, you were going to say something.
The data, though, when you look at the data that we presented, TAVR is potentially superior even among this
that's
young,
what got my
healthy
attention.
population. So if you're a 62-year-old and you're thinking, I could have a stroke at surgery, I could have one at TAVR as well, but the risk is lower. And remember, we're talking about 62-year-olds. These are people who are truly in their prime. Okay, most of these people are still working. They're in that point in their life where they have enough life experience that they can, whatever they do, they're doing it very well. These are the patients where you can't afford to have a complication.
Yes.
Minimizing things like strokes and so forth in this population is very, very important.
And it's the Achilles heel. It is, stroke is the Achilles heel almost of everything that we do. And stroke mitigation is, I mean, like I think that we've got to get better at it for everything, including just standard going on pump, cardiopulmonary bypass, putting the aortic cross clamp on, shower of, you know, gradu, as we call it in Louisiana, or athroma, or whatever else gets flaked off, removing it, more gets flaked off, what got trapped under the clamp that just crushed it, and there's an event, and it's, you know, stroke is devastating, and it doesn't even have to be a completely debilitating stroke.
No.
It could just be the nuance of Uncle Joe just isn't the same.
Same.
Right.
Like I said, a lot of these people are in the prime of their careers, and potentially you take that away from them at that point. And apart from stroke, there's a mortality advantage as well. So if I'm a well-informed patient, even at that young age, I may be thinking I'd rather have a TAVR than have a SAVR simply because it's a lower risk procedure for me. And the rate at which the technology is progressing, we will probably learn that TAVR and TAVR is possible over time. I don't know that that's going to happen, but I don't see why that won't be possible given the successes we've seen in the technology over the last decade.
Yeah, and I think that this is, am I interrupting? Do you need to say, do you have a question? And I think that you bring up so many good points, because from a professional, selfish professional perspective, SAVR is something that is a bit more of a benefit to me because you need to go on pump. Nobody's going to do an off pump at AVR. Never going to happen.
Correct.
Okay. However, and I think this is how we as a profession will survive, and I say this to my colleagues out there as well, partnering with you for the ECMO support, having, you have to reinvent yourself, and becoming that, having that piece associated to these procedures, again, going full circle from what I started this whole conversation off with, makes much more sense to me, and providing him the circulatory support he needs that he can do without necessarily having the surgeon's capabilities there, because there's nothing they can do at that moment other than, I guess, help you put the patient on ECMO, but you could do that all by yourself. That's kind of how I feel.
Well, I think it has to do with an evolution. You have to grow, as technology and techniques change. And I think that's the point that Dr. Balan is making, is that maybe you don't necessarily agree that the surgeon needs to be, scrubbed in and in the room, but this is a part of the surgery and interventional cardiology's evolution of how they're going to become more of a collaborative team. And I think especially in the early stage of this, it's very important that they are developing this road together.
Good point, very good point. But, you can't ever, I try really hard, and I think all of us do, try really hard to not let self-interest interfere with our best decisions.
Sure.
But sometimes that's really hard to do. Wow. So yeah, I'm telling you, I'm just being, I'm being provocative, and I'm being honest about things, and that's just a reality. We have to work at that.
But if you broaden that out, though, what is absolutely necessary as TAVR moves out into the community? What's absolutely necessary to have in a center to make it a successful program?
I think the key things are this collaboration between surgery and interventional cardiology. I do think that there has to be some bailout piece that is thought out and well planned ahead of time, because you don't want to figure that out when things are going wrong.
Right.
And then the third piece is the support piece from the CCU nursing standpoint, being able to have the social infrastructure to get these patients in and out of the hospital. These are patients that live their lives in an outpatient setting. They come in for an acute procedure, and then we have to transition them back out to their outpatient lives. And sometimes that, many of these patients are older and frail, and they're walking around they're hobbling around with a walker and so forth. They need physical therapy, things like that. All of those kinds of components are part of this multidisciplinary team that is necessary to build a successful program.
Very good points. Something that struck me on your numbers, and I only have two quick questions left. The first one is kind of just sort of a side question, but you did 38 plus or minus 38,000 TAVRs in 2016 at between 500 or 600 individual places. But in the entirety of 2016, actually take that back, not 2012, we did 35,000 isolated surgical AVRs. Now, some of that can be attributed to the 38,000, that some of those patients were non-surgical candidates and therefore didn't get put into that arm. But I believe, and I may be wrong, but I believe that isolated aortic stenosis historically has been underdiagnosed and treated in the past, or those surgical volumes would have been much, much, much higher.
Correct. I agree with you. There is a lot of undetected aortic stenosis out there, because this is a disease that is slowly progressive. That is the natural history of this disease. People get older, they feel like they're slowing down, and they think, I'm just getting older and slowing down. Unfortunately, many people don't have regular access to health care. No one's listening with the stethoscope necessarily. No one hears the murmur. Then all of a sudden, they end up in an emergency room somewhere in respiratory distress. And that's when it's picked up. And by then, you're already too far down this road.
Yeah, your
because-
mortality benefit isn't there once you've gotten to that point.
Yeah.
In fact, that's been looked at both surgically and with the TAVR literature. Once you get to an STS score above 15, it portends not only poor outcome at surgical AVR, potentially portends poor outcome at TAVR as well.
But having the TAVR would probably at least, I think a lot of those patients probably improve quality of life. Maybe
Yes.
not duration, but
Right.
quality.
Might not extend their life, but it improve what they have left.
Looking at the Cohort B data from the original partner trial, we will extend life. If you can bail a lot of these patients out. And I've done a lot of, I do a lot of the very high risk
Yes,
procedures. And yes, it's a lot of those patients.
seemingly
that-
only.
Sadly, yes. I wish it were better, but yes, I do kind of specialize in the high risk. I do think that we can continue to bail out a lot of these patients, but among that population, the morbidity and mortality is going to be higher, simply because they're coming to the procedure at a much higher risk level.
Sure, absolutely. Okay, my last question is regarding the stroke, since I had talked about that being such a huge problem, because you can have the type 1 stroke, that what we all understand to be a stroke, where it's obvious, and then of course the type 2 stroke, which is the diffusion weighted MRI and various events that occurred that we believe have long-term consequence potentially, that are just not seen at the moment. And that's pretty high, I think, in both SAVR and TAVR. I mean, type 2 stroke is very common in any intervention like
Correct.
this. So it's not isolated to TAVR that it's the boogeyman problem. However, with the smaller delivery systems and the potential that you showed of going in the axillary artery for the implantation, when I watch the TAVRs done and I see that big valve and delivery system, albeit smaller than it used to be, going up and making that turn in the arch and all the way along that surface, we know it's a chisel and it's chipping away whatever, and it just can't be helped unless we get to the point where we have autonomous catheters that can stay central lumen through some type of fancy computer system and drive itself around and not bang against the wall. But if you came in through the axillary, through the innominate and down, that seems like so much more anatomically suitable. What are your thoughts on that?
The data actually does not bear that out. The stroke rate's higher with transaxillary.
Really?
Yes. Particularly the delivery from the left is actually much more anatomically feasible, because when you come from the right, you kind of have to make this sort of bend into
Yeah, I can see
the
that.
annulus.
This
Whereas
makes more
from
sense.
Here, you can curl in nicely.
You're at least
to the
right. You're at least sort of on
You're-
a
Same plane.
on a transverse plane
Yeah.
coming
Correct.
into the arch.
Which means you then cross all the head vessels at a very proximal location
Yes.
with your delivery system. And delivering that sheath from the axillary, this was a sheath that was designed for the femoral artery. It doesn't move as well in the axillary position. So
Okay.
I do think that we end up just scraping off more stuff
Really.
from the axillary then. I've seen rates as high as 6%. from the
That's high.
axillary. Yeah.
That's very high. Yeah.
As compared to the data that we just
But
saw.
of course,
where we're
surgical
less than
AVR stroke
2%.
rate is 5 to 7. I mean, it's high.
But
It's
with
not low.
transfemoral TAVR, we're talking less than 2%. So.
That's a good point. That's a very good point. So, of course, we need to bring you back, and maybe you could find a colleague that would like to participate as well to discuss cerebral embolic protection and how we do that. And maybe we won't say it on the air because I think somebody will take our idea, but we need to work on that and maybe even show our own data, which I think would be really cool to do.
Yes.
And but don't tell anybody.
The important point that you bring up is there are devices now in the realm of cerebral embolic protection for TAVR. The Sentinel device is FDA approved for this. The TriGuard device has completed its trial and awaiting FDA approval. I don't think we know what those trial data are at this point. Basically, these are devices that cover the arch vessels and try to catch some of the debris that's going north during the procedure. And yes, while the original trial that looked at Sentinel didn't quite meet its endpoint, there were a lot of facets to that data that seemed to indicate a trend towards benefit. And a lot of the registry data that has been accumulated over time seems to indicate fewer cerebral embolic events with the use of cerebral embolic protection. So I do think that that's going to become the standard of care with TAVR. I now use the Sentinel routinely for my TAVRs unless there's some anatomical contraindication to using it. And I do think that is part of what has helped drive down some of the stroke rates. We were allowed to use Sentinel towards the tail end of PARTNER 3. So,
and that's a whole new industry that was launched.
Correct.
As you know, as a result of the concerns over TAVR and stroke. Sure. But I think that again, I think surgical AVR has its own Achilles heel. Surgery has its of any sort, even bypass surgery has with it an inherent risk of a neurologic event of some form.
A diagnostic heart cath carries with it.
I've seen people stroke from it.
Yes.
It's happened.
Correct.
Absolutely. Well, any final thoughts from our esteemed panel?
No.
No? No and no? Dr. Balan?
Thank you for having me. It was a pleasure.
Thank you for being here. Now it's time for some good lunch. And just so everybody knows, if I could add this, please. Dr. Balan helped me more than anybody I've ever known understand vegetarianism. I said, okay, well, can you eat this? Can you eat that? Do you eat this? Do you eat that? He says, okay, Joe, let me keep it simple for you. If it has eyes, I don't eat it. So we have made some great vegetable options for you, but I've asked everybody back there to pin eyes to everything.
Fantastic.
So every cucumber you see today will have two eyes looking at you.
Me?
Yes, sir, it sure will.
Great.
All right, thank you all very much. Listen, we will see you next month.
September 21st.
September 21st, thank you. And we're going to be doing controversies in perfusion with transfusion, del nido cardioplegia. In fact, I'd love to get Dr. Wind up here to talk about that.
Absolutely.
If you can help me with that, man, I'll tell you what, that would be appreciated a lot. And should we be treating elevated potassiums coming off pump? John Ingram is coming from Florida. I think you all know him. We're going to be talking about metabolic alkalosis, which we really don't understand, but don't do anything about. It doesn't really matter. I think it can be controversial. We'll figure that out. When to call for ECMO, Dr. Samir. You know Hani Samir? Dr. Samir? Super guy. You need to meet him too. Also talking about ambulating the ECMO patient. These aren't septic patients or acutely ill patients. These are generally chronic patients who are waiting for a lung transplant or something like that. But keeping them conditioned is critically important. Probably the most important talk that we're going to give, and you've given it before actually, when not to call for ECMO. Sometimes that's as important a decision as when to call for ECMO, because when you put them on, you now own them. And that's sometimes a real problem. Making that decision is tough, but it's an important topic of conversation that I think we need to discuss. So we will see you all on the 21st. We'll be starting a little earlier at 8 o'clock in the morning, and it's going to be approved, the whole program, for 6.0 Category 1 CEU by the ABCP. Do your evaluations for this program so you can get your 5.7 Category 1 CEU by the ABCP. Today, I think we leave it up for about 2 or 3 days so you can get the evaluations and so forth done within the system and get your certificate put into your folders. Thank you all very much. We'll see you on the 21st.
Thank you.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are three categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are three things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive two-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive two-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perforation, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.